So we're actually going to pick up on some of the points that Senator Cassidy made as we turn our attention in this next panel very specifically on COVID-19. Now, yesterday, for those of you who couldn't join us at the beginning, we heard from the White House, from Dr. Shuker and Nunes Smith, about the Biden administration's plans for tackling the challenges ahead, not just getting vaccines into arms, but also addressing deep inequities in health and healthcare. So on the next panel, we're going to delve more deeply into the lessons learned by the key players at the front lines of the pandemic response. And of course, then, what this means for the future. Now, our four panelists who are going to be turning on their cameras and joining me here are going to introduce themselves, but let me give you a preview that they bring the perspectives of health systems, hospitals, laboratories, and state public policies. Each of them will kind of tell you a little bit about themselves. You can read more about them in the program. So now let me, all right, you will, I'm just checking my video. Great. So let me turn first to Shereef.
Thank you, Dr. Simpson, and thank you to AcademyHealth and to the Senator, of course, for your opening remarks for this panel. Shereef Elnahal, I'm President and CEO of University Hospital in Newark, New Jersey, affiliated with Rutgers New Jersey Medical School, Level 1 Trauma Center and a safety net institution, very importantly for our region and our city here in Newark. Was formerly the New Jersey Health Commissioner under Governor Nemours for his first 2 years in office here in New Jersey. Thank you.
Great. And thank you for joining us, Shereef. And we're going to use first names in this panel. So please, we've all got our official titles. Kara, you're next.
Good morning, everyone. It's a pleasure to join. I'm Kara Walker, family physician by background and training. I am currently the Chief Population Health Officer for Nemours Children's Health, but had the honor of serving under Governor John Carney as the Secretary of Health and Social Services for his first term, and just completed that work all the way through July. So saw the first wave transition to a health system to see this second part of our response around COVID. I'm pleased to be with everyone.
Great. Thank you, Kara. Welcome. Brian.
Hi, Lisa and attendees. I'm Brian Caveney. I'm the Chief Medical Officer and President of Diagnostics for Labcorp. And we've had the honor of being both the first commercial lab that brought a COVID test to the States and performed now almost 40 million COVID tests. But also we were very instrumental in 74 different molecules under review, from monoclonal antibodies, the antivirals, as well as most of the vaccine candidates under review in the United States for both the diagnostic testing that we do as part of the trials, as well as the clinical research protocols as well. So we've seen COVID roll out from lots of different angles.
Yeah. Wow, Brian. Absolutely. So, and rounding us off, we have John. John.
Yeah. Hi, everyone. My name is John Brownstein. I am a professor at Harvard Medical School and the Chief Innovation Officer at Boston Children's. My background is infectious disease epidemiology, so I guess they often call this our Super Bowl. But my work has been focused on both digital health efforts at the hospital, where I run an accelerator and help implement digital tools to our patients and providers. And then also on the public health front, building technologies to support both the federal response to the pandemic, but also global response. And so we have this perspective of both the public health side, but also the clinical side. So it's great to be here.
That's wonderful. Now, before I get into the next round, I have to ask, John, is that a pillow of Tony Fauci?
Yeah, it's Fauci on the couch. He's been with me for many months over my shoulder, guiding me through this. So yeah, I had to straighten him out just a second ago. He was slouching a bit, but yes, that is Fauci on the couch.
Fauci on the couch. I love it. That's great. Now, so my first question, given the amazing range of experiences and backgrounds you bring, you've clearly been at a lot of the different front lines that we've experienced in this pandemic. So, I'd like you to reflect on sort of your experiences to date, and as you think about it, what surprised you the most during this past year, and what were you least prepared for? Because that's going to help us think about the future. But, what are some of your lessons and aha moments or maybe disappointments in the last year? And let me start with maybe John.
Okay.
Start with you.
Happy to kick that off. Right. I mean, I think many of us will have experienced very similar, very intense years, both, incredibly fast and slow at the same time. In our view, sitting within the health system perspective, really recognize that it takes an emergency to catalyze the change that we've been seeing. I mean, we've had a telemedicine program and efforts in digital health for so many years, but it took this moment to bring all these stakeholders together, to clinicians, researchers, business leaders, and we've seen sort of an unprecedented level of innovation, both within our system, but also on a global level. And of course, we'll talk a little bit later about some of the incredible partnerships on the private side that have emerged. And, in my view, hospitals themselves are not known for their agility at all, I would say. But I would say at least in 2020 and maybe still in 21, I think we were agile in the sense that we built an accelerator to really identify and prioritize pain points and actually build on them. I mean, we selected a bunch of different innovations, whether it was increasing in testing capacity or 3D printing, various digital toolkits. We implemented contact tracing protocols, and of course, telemedicine, which we've implemented at a significant clip. And so, we've built sort of what I think is a foundation and the institutional muscle for digital health in a way that we did not have. And now this is like the starting point, right? We've done this. What can we do to push out more broadly some of the initiatives, whether it's remote patient monitoring or AI, connected devices, all the things that we've been talking about at this conference, many others for so many years. I would say on my public health side, the open data sharing has been the incredible sort of experience that I've witnessed, where we're seeing data across different types of often siloed organizations contributing information. We launched a platform called Global.Health, which pulls data from all sorts of sources to provide the most amount of detailed data that can help us respond to the pandemic, whether it's understand the value of lockdowns or masking. And, I think what we found is finally some of these new data streams, and we'll talk about it maybe later, social media and other types of data streams, which now have played a much more key role in the response. And so the data landscape maybe hasn't changed dramatically, but the leveraging of that data has changed. And, hopefully that is something that will be here to stay.
Yeah, no, that's really exciting. Yeah, and it speaks to a lot of what Senator Cassidy was alluding to in terms of all the different data streams, and of course raises those questions of privacy. So, Brian, how about you? Lessons learned, experiences?
So many. Well, John made some really important points, I think, that apply across the whole healthcare system. Another that we were right in the epicenter of is the fact that we, of course, knew that it's a completely global supply chain, whether it's all aspects of diagnostics, from the consumables to the equipment, the reagents, the primers, but the personal protective equipment, the gloves, masks, everything else. All of the different components for the clinical and drug research necessary and the chemical manufacturing that takes place. Incredibly global supply chain. And when we had in the early days of the pandemic some very specific border closures of both political and health reasons, that massively disrupted the supply chain ability to move those goods around the world. And in particular, so many of those important things are made in other countries and then brought to the States for the things that we need to do. So we were constantly working very closely with the government representatives, Homeland Security, the TSA, customs, whatever, every single day to get the things that we needed to massively scale up our testing and our drug research. That was really critical. I mean, just one small anecdote in that most of you will remember that the first real epicenter outside China was near Milan, Italy. Well, it just so happens that the by far most important nasopharyngeal swab manufacturer in the world is Copan, which is just a couple of miles east of Milan, which was shut down, which many of you remember the massive global shortage we had in swabs. And you'd think it's just a Q-tip. Why is that a big deal? But that was just a really important component that we needed to deal with. So our business continuity and emergency preparedness plan for years, and most other large companies, is redundancy in different geographies of our IT system and everything else. And we made a decision very early on that we needed to make sure we had many different labs all across the planet, but particularly across America, to be able to perform it. And just in the last 2 days is so important with all of the winter storms, because we have several of our major laboratories either offline or on generator on limited function. We're diverting so many clinical specimens, not just for COVID, but for all of the other 5,000 tests we do, to our other labs. And so having that logistics and IT interface and redundancy worked out ahead of time is just critical for the continuity purposes. And we've got to get a lot better at that as a country and as a healthcare system for whatever the world throws at us next, including the next pandemic.
No, that's a great point. And that global dimension is something that's really been brought home to us of, how we're all connected. I have to say, I've learned more about logistics as a physician trained, I never knew logistics were so critical to, getting what we need. So, Kara, your turn. What are some of your reflections?
Hi, everyone. I think that looking back, I think the intersection between politics and public health and how those came together were pretty shocking and surprising to me, that we had no ability to bring those two worlds together in a coordinated way as a nation, and certainly at the state level. So we were constantly debating from public health response how to make sure that we kept the economy going, that we kept people safe. But unfortunately, what ended up happening is those two worlds completely collided, right? Our healthcare professionals were at the intersection, and sadly, we had a massive number of deaths, where the US accounted for 20% of all COVID-19 deaths worldwide because we couldn't figure out that intersection. I think that was incredibly surprising, shocking, and hit us all hard while we were trying to keep people safe with essentially common sense recommendations. I can't tell you how many times I probably repeated, wash your hands, stay away from people, stay home. Well, the reality is, shockingly, some people couldn't stay home because they could not put food on the table and pay their rent and stay housed if we weren't able to make sure that they also could go to work. I think the ripple effects were intense, where that led to nursing home deaths and other inabilities to protect our most vulnerable. I think for this community, what I was also surprised by and pleased about is that we were able to mobilize the data infrastructure in ways that probably in state government would have taken us decades. The reality is, we also recognized some of our data was just poor. We didn't have enough of it. We needed more information on race and ethnicity to track where our equity outcomes were going and what was happening on the ground in communities. And we have lots of missing data even now that we're still trying to overcome, report on at a national level. I think that is something that we have to think about going forward. I also have to say that I think we mobilized quickly to engage our vulnerable communities through contact tracing efforts and community health workers, community response teams. But I would think we would have been better prepared to do that and combine it with the resources needed that they needed most around PPE, around education, and again, public health strategies that have worked for Ebola response and other pandemic-like efforts, yet we could not seem to get that through. And I think that was incredibly frustrating. It took longer than I think it needed. My final reflection around where I think were least prepared is around the outpouring around anti-racism and around our need to focus in on equity. So overlaying the widening of health disparities with the pandemic, our lack of ability to have good information in the hands of policymakers, combined with social reckoning and a real need to embrace these issues, I think was something that we were not prepared for as a country, not prepared for in an ongoing way. And I hope that, again, this is a lesson learned that we will continue to move forward. But I think we have immediate lessons around vaccine access and strategies to make sure we're not continuing to widen those disparities moving forward.
Yeah, it's great points, Karen. My first real job, I like to say, after my 2 residencies was in a state health department. And, so I have a fond place in my heart for the role of public health at the state and local level. and we really have underinvested. So, I mean, in Delaware, the fact that you even had data, I mean, so many health departments and particularly locals just do not have the data infrastructure they need. And then the connections between those data, that really opened that up. So let's hope we're serious about investing going forward. Shereef, you're bringing up the rear, so to speak, on this last round. And, you know, you've been at ground zero, really, since the beginning in this country. So tell us what it was like, what it's been like at the hospitals.
Yeah, thank you, Lisa, and appreciate actually going last on this question, because I can tell you we have interfaced with literally every topic that's been mentioned by my co-panelists, everything from jockeying for personal protective equipment as a standalone safety net institution against massive, nonprofit health systems that primarily serve suburban communities and are cash rich, trying to integrate all of the new technologies and everything from testing to data and surveillance for our own communities, and even the politics to this day. Just an example that Kara mentioned, we have folks who are anti-vaccination special interests trying to fund activists of color here in Newark to actively, disparage the vaccination effort and everybody behind it, and lie to people and spread disinformation. And so we're facing all these challenges at once, but I do want to hone in on the picture that we saw around the cracks in health equity that essentially became earthquakes in our community. Walking around as a leader in our hospital, doing everything from trying to bring PPE to the units during the worst of the surge in the Newark area to talking to people and trying to understand, what they were facing, ratios of patients that they've never seen before on the nursing side, pharmacy worried about running out of sedating medications for people in our ICU, which would have been disastrous, folks trying to get PPE every day from supply chain to delivery. And we couldn't help but notice every single person in our hospital that was filled with COVID patients was a person of color. And we have a much more diverse community we serve at baseline. And that was heartbreaking. And we saw it in, unfortunately, I hate to paint this picture, but refrigerated trucks that we had outside of our hospital in our massive parking lot for folks who passed away, and dealing with the funeral homes, and talking with our allies in the community, everyone from the faith-based community to nonprofits and others who have the trust of people. And we saw the worst of the health inequities that exploded during this pandemic. And so as we are proceeding through trying to build trust in the vaccination effort, and trying to get people to show up for COVID testing, and continuing to emphasize masking and distancing, which has never been more important, despite the fact that you're seeing numbers trending in the right direction, we are very focused on making sure that our community is tuned in to the truth. And every way that we can do that is just exactly what we've been focusing on from the beginning. And we're starting to see movement. So we had 40% of people in our community who are willing to take the vaccine in the fall. And now, after diligent efforts, that number is just over 60%. And this is a majority minority community, greater than 80% Black and Brown residents. And that's possible through trust and leveraging what we were able to in terms of the trust that we had built before this pandemic, but also importantly, when we've guided people through that journey to finally accepting the vaccine, there's always a caveat to that, which is to say, we have had public health issues plaguing our community from day one, and you've proven that you can mobilize the funding, the will, and the taking literally all risk out of the pharmaceutical industry in bringing a therapy, a vaccine that works to get us out of this pandemic. What about late-stage breast cancer in Black women? What about colon cancer and rectal cancer and prostate cancer in Black men? What about chronic disease in our communities? Where's the will and the effort to do that? And so we have to make a promise and fulfill that promise to the community that we are begging for their trust at this point on the vaccine, because it impacts all of us, and deliver on that. And I know that data, and Kara mentioned the visibility of that data to policymakers and health system leaders and everyone in between on race, ethnicity, and outcomes needs to be shored up and improved if we're able to do that.
Wow. Yeah, absolutely. Well, So many great points that you've each brought up. I mean, throughout the importance of data. You just can't do care or policy without this data. That's clear, despite, limitations and some opportunities there. Shereef, I'm really glad you brought up the issue of trust as well as misinformation, because that is plaguing the conversation nationally. Sorry, bad use of a term. And in fact, there's a session, our closing plenary, please join us then as well, if you can, where we're going to delve specifically into rebuilding trust in science and the health system with Sudeep Parikh from AAAS. So these are really important ones. But I want to sort of come back to the will point, Shereef, that you made as you each touched on inequities. And so, where are you seeing progress? Because, we as a country, we've known about these for decades, for centuries, and we've done a, cynical, very good job of not addressing them. So how do we not lose the momentum? How do we actually change things across the board, public sector, private sector? What are you seeing different on the ground in your organizations that feels, tangibly different and sustainable, that we're going to make more progress this time? And anybody want to jump in on that one first? No particular order here. Or else I'm going to call you out.
I mean, I'm happy to begin. I think we took this moment this year as a real point in time to make real tangible sort of changes to our organization, both at a top-down and bottom-up approach. I think that, of course, time will tell if these are sustained, but there is a stated commitment and designated teams, at least at the C-level at our hospital, fully appreciating the need for considering equity and diversity. I mean, we've also approached it from a funding perspective because we got a large FCC grant that allowed us to provide immediate support in Wi-Fi enabled devices to alleviate this digital divide. But more broadly, I mean, this is an area where it's top of mind, but on top of that, increased data is being collected to allow us to fully understand and illuminate gaps that exist. We clearly have important gaps within our own hospital that we are now trying to account for. I think specifically within our own innovation group, we're trying to build the infrastructure to both identify but also measure access to disparities across our vulnerable populations. I mean, we have a significant portfolio of startups that exist within our group. They have not necessarily stated EDI as a priority, and so we are digging in with those groups to make sure that that's a priority as we think about what we're vetting and bringing in and how we're prioritizing technology. So it's a clear sort of mandate on our group that we are sort of responsible for and reporting on constantly. And so, we are sort of judged by our ability to expand our referral channel to additionally think about underserved communities and the partnerships that sort of bring better care. So again, I think the proof will be in the pudding if these things last and people really devote the resources consistently. But as far as now, I mean, we've really seen a fundamental shift in how we're doing our own business.
Right. Brian, let me ask you, I mean, your reach and just, the comment about the snowstorm and, all the many challenges that you're confronting. How's it changing your strategy?
Well, I would commend Senator Cassidy and many of our other legislators for one of the bright spots, I think, early in the pandemic response was the CARES Act and the Families First Coronavirus Response Act. There were some provisions in there that were very specifically targeted at going after traditionally underserved communities. And that enabled us, in working with the Department of Defense, the White House Task Force, some of the retail pharmacy partners, as well as the states that were organizing the federal testing drive-throughs in the early days, if you remember, before the vaccine. So in some of those planning sessions, we were very specifically able to target communities that were traditionally underserved and not have to think about whether there was going to be reimbursement or those kinds of things, but we could very specifically target those communities. So one tiny little example, but I think a bright spot of something that worked in the moment that was able to deliver care where it was needed. Now, on the flip side, I would say that even though we're very proud of the fact that we were part of many of the clinical trials for vaccine manufacturers bringing vaccines to market here and abroad, a very significant proportion of our own employees are people of color in communities all across the country. Phlebotomists, couriers, people that do accessioning are lab techs. And even though we've made an enormous push to provide education, information about the health department websites, et cetera, for our own employees to get vaccinated. We are even seeing in our own employees a pretty significant differential in vaccine hesitancy in certain populations. And so even a company that's trying to be part of the science to address the situation experiences that same overlay. So it's clearly a national problem that we have to have a deeper conversation on and really, really focus resources and effort on this over time to think that we're going to, significantly and appreciably improve.
Yeah, that sustained focus and investment is critical. Kara or Shereef, any additional comments before I want to turn to data next, but want to give you a chance to weigh in on this one.
So, Shereef, I hope you don't mind if I jump in. I'm sure you have a lot of thoughts about this as well. And because you're in a health system now, I'll focus in on the state level responses that, as a recovering public health official, it is still very close to my heart. I think what happened is that we were able to think about those disparities and equities strategically. And so Governor Carney elevated some of the work that was already happening in so many state agencies, but elevated it to the governor's level. And I think that step was critical to add resources, leadership, and focus. That also means that the business community can come together around looking at their own opportunities to examine board leadership, examine their own C-suite leadership for ways to increase diversity. We know that matters. I also was impressed by those states that acted very quickly around establishing racism as a public health, as executive order, where they wanted to require trainings. And some of this work was out of Michigan under Dr. Khaldun, where we were really looking at models to make sure that we started to think about the public health threats of racism in what we're doing in health. I also know that so many of us are just trying to figure out how we embrace this moment to undo some of the underfunding by government, right? I mean, it's deep, it's longstanding. We can't undo 60 or 70 years of a lack of investment in Black and Brown communities just by elevating and talking about it. We actually need to put money into those efforts. That is going to take time. And so I am optimistic, but I think it is challenging when we see some of the pushback around how we truly invest in our communities, how we lift up multilingual social media campaigns to the same extent we're doing it more broadly. And certainly thinking about our children right now is near and dear to my heart, working within Nemours, where some of our educational disparities that existed will need to have a renewed focus as we emerge from this pandemic where, right now we know a lot about trauma and adverse childhood experiences and they matter, but rebuilding around the disruption that's happened in education and early care and education and childcare is going to take a focused effort on parental supports. The Biden administration is certainly picking this up and lifting up ways to put more investments in, but we all are going to have to stay tuned and pay attention to where the dollars are going and pay attention to the impact on the opioid crisis and how drug overdoses are escalating potentially. We don't know yet about other family impacts in terms of mental health. And I think we're going to have a lot more to do, but at least we're having the conversation. And I think that is a start to progress.
No, great. No, and I'm so glad, as you know, that you mentioned kids because, while they're not, the pattern, the epi is changing a bit right now that we're hearing more about more severe cases, but appropriately the focus has been on the elderly and those adults with, high risk conditions. But the impact on this generation of children of this pandemic and on their parents and their education and their social needs, let's hope there's a sustained focus on that. That's my own personal Lisa Simpson, pediatrician by training, pitch there to public policy. Shereef, if you don't mind, I'm going to dive into some more data related questions because after all, this is the Datapalooza. And so, you've all touched on how you've been using data, the public, the private, some of the innovation, but, how have innovations in analytics like AI or ML, all these sexy acronyms that are out there, Is that actually, is it helping you, and is it going to help differently going forward in terms of pandemic response, this one or the next one? Or what else does the data ecosystem, the data community need to do to step up their game in this space? Where are you going, John, with some of the investments? Let me start with you.
Yeah, sure. And maybe I'll talk a little bit about some of the partnerships that we have had over the past year. One of those is on the data front, collecting better epidemiological data to actually respond to this pandemic, but also future pandemics. And, we've had a huge amount of sort of resourcing and support from companies like Google and Facebook. Google providing, deep resourcing, their tech background in order to actually build open platforms around data sharing. Clearly, that was a miss at the beginning of this pandemic, where we didn't have full insight into detailed epidemiological data that could have really supported our understanding. So trying to build that new infrastructure now has been key. The second is Facebook actually launched probably the biggest global public health survey ever done, right? They have the survey that is collecting symptoms and other associated topics like behaviors around masking and contacts and mobility. They are capturing data at a level that no epidemiological study has ever captured. And so we have been able to do things like understand the value of mask mandates or social distancing because of that data was made available. Now, the question is, do those companies continue to invest? Do they continue to support? Are we then left holding the bag? It was a little bit actually like during the H1N1 pandemic, where Google launched a tool called Vaccine Finder. Our team actually took it over, and we're in the process of almost launching this pretty soon. Hopefully within the next week or two, which will be the national site for people to figure out where to get COVID vaccines. Now, Google invested in those during the previous sort of pandemic, H1N1, walked away. Now they're back again. But, we've been holding, this system together with, like bubble gum and tape. And so, the question is, can there be sort of full investments going forward? Is there a recognition that these tools need to continue to exist, that we need to collect better data on pandemics, that we need to provide better tools to allow for communities to access vaccines? Those are the partnerships that academic groups like ours, public health departments, they just don't have the resources to do. So again, that great innovations, great sort of access to incredible data. I just hope that continues, next year.
Yeah. Shereef, do you want to jump in on the data question?
Yeah, I'd love to. And I really second both Kara and John's comments here. One thing to bear in mind from the data we do have on, for example, vaccine acceptance, the Kaiser Family Foundation did analysis on the prevalence of skepticism and the level of skepticism in different communities by demographic. And if you look at that, of course, you see that Black and brown people do have some of the highest rates of hesitancy. But they also have among either on par or lower than other demographic groups on being absolutely against categorically taking the vaccine. And so what that means is there's a different source of skepticism in these communities that we have to consider. And it also is a source of optimism, because that means folks can be moved if they are engaged humbly with recognizing the systemic racism that has plagued these communities for so long, especially at the hands of the medical establishment. But very importantly, while that is a source of optimism, what we hear from community is that, listen, we understand that you're trying to collect data. We understand that you're trying to report on the status of the inequities that we're facing. But we're a little bit sick of published papers on our problems and very detailed characterization of things that we're facing. We want execution. We want data that is actionable on behalf of you as a health system who serves us. And we want you in the community responding to that data and showing that data moving in the right direction. And that's really important for us to focus on. We can make our analytics as perfect as we can be and as insightful as we can be. But for example, if we don't solve structural issues like the digital divide or like trust in contact tracers who are calling people of color all the time, trying to understand who their contacts were after they were diagnosed, if people are hanging up the phone or they don't have a smartphone to tell you what they're experiencing, and if people are responding, prefer not to respond when they're assessed on their race and ethnicity with regard to any survey, then you're not going to get anywhere despite having as perfected as much as possible these back-end systems. And so I just want to make sure that point is made on behalf of folks that we're serving and what we're seeing in our community.
Yeah, great. Really important point. Brian, do you want to jump in on this issue of data and what you guys are really seeing?
Absolutely. Yes, because we created so much of it. And maybe another bright spot in why it's just critical for public-private partnerships to take place, and maybe even something that wasn't really well reported on last year because we took for granted, but thank goodness it already was pre-existing, because it would have been almost impossible to build on the fly in the midst of an early pandemic. And that's the electronic interface that already exists in the communicable disease reporting across the country. And so while we're honored to work with hundreds of thousands of physicians, they desperately needed information around who to test and when. And so that needs to come from the authority, right? The public health agency, particularly the CDC, to set those guidelines and rules. But then it's the hospital labs and the private labs that have the electronic interface into every doctor's EMR, so that when that was ordered, the information would be put back electronically into their EMR so doctors could find it, mine it, collate it with the clinical information, do all the other things they needed to do. But critically, in terms of the speed with which things were needed to be reported on and were scrutinized in the media so much, was we already had in place for decades the electronic interface with the state health departments and the CDC to report the results of the COVID tests, the antibody tests, now the antigen tests and others. That already existed. And so we were able to very quickly get that data to them. And in terms of, and I completely get the speed with which decisions were made, but we were getting phone calls from literally every governor's office and people from every state saying, send us the data, send me a spreadsheet or send me a something or other. And we would say, could you please call this person at your state HHS department, because they're getting an electronic feed from us every 12 hours with every single test from a citizen of your state. You already have it. We're delighted to walk you through it. We're delighted to work with them, with you, but creating separate reports outside the normal system that's functioning effectively is probably going to create more chaos. And so let's be on the same page. So I think that was a really important bright spot. We certainly can improve upon it. We can use it for more things in the future beyond infectious diseases, but that the bones are there for us to build pretty interesting models for data sharing in the future.
Yeah. And the question when we talk about public-private then is also always the variation across states, because, the infrastructure, I mean, this is the way our country addresses health and healthcare, and that's a big strength, because we're a big country and states are very different, but it's a critical weakness when it comes to some of these infrastructures. I was on a coffee chat this morning with Jesse Tenenbaum and Terry Cullen. They were hosting, and it was just fascinating hearing about North Carolina and some of the ways they were using the data to pinpoint, vaccination uptake rates with, marginalized and vulnerable populations, and doing that in real time, dynamically, to then adjust, their vaccination strategies. So that gives me hope. Let's just say that, that we're going to be able to get better at this, as long as we, and back to Shereef's point and others, of building that infrastructure of trust. And, if we can get it right with the vaccination, maybe I'm being unduly hopeful, but maybe then we can also address all the other health needs that persons of color, communities of color, communities that have been disenfranchised have had for so long. So we can, try to, really rebuild in so many different ways. Data points. Anybody else want to weigh in on this one, or should we move on to another dimension? Okay.
No, I think I'd love to weigh in. Lovingly called Dr. Data by our Lieutenant Governor. She would often call me out on it. But I think that the data was essential, but also having people who know what to do with it is critical. So there's a link between publishing the data, putting it out. We made a very beautiful dashboard, borrowing some lessons from Rhode Island and others to make the data make sense for communities so they could look at it themselves and say, we need a testing site tomorrow because see how our rates are popping out, and you could, manipulate it by census tracker, zip code. But I think that there is still a need to make sure that you have a robust infrastructure around those who know what to do with the data. And so we had, one state epidemiologist in charge of our response. And we tried hard to recruit, but can you imagine? Epis were, in high demand during a pandemic. Who knew? So we also have to invest in that pipeline of those who are data scientists, who know how to leverage the data. And, I think to the point of asking others to bring in their expertise through public-private partnerships, we had to lean in there as hard and fast as we could, but also recognizing because of privacy and some of the restrictions, it was very hard to set those arrangements up and use the data in an informed way. But, I think we are getting there. And again, I think the more that we can put data out transparently with robust measures in dashboards in ways that communities can use it, the better off we'll be for the future. So I think that is a bright spot too, Elisa.
Great. Okay.
Yeah, I can just add on to that. I mean, I think that's such a good point. I guess maybe the question is, we've had to rely so much on partnerships, right? Like outside groups building the dashboards and tools and data sets because we didn't have that capacity inside, right? COVID Act Now, COVID Tracking Project, COVID Exit, all these tools that came up, and they were doing incredible jobs of getting information out in clear ways. But it also spells such a big gap that we have in public health around data literacy and science and tools. I mean, I hope that we're going to see a new sort of set of workforce come in if the funding is there to support it. But I mean, unfortunately, we had to go to those outside groups that are building these things on the fly. There was no sort of internal capacity or infrastructure. And that is pretty scary, I would say. I mean, of course, there are high resource public health departments like New York City and others that had that capacity, but far and few of those could really do these kind of efforts on their own. And of course, it's spelled to some of the challenges in the federal-state relationship as well. But I mean, there are some serious gaps that we have in our current public health workforce for sure.
Yeah, absolutely. And I'm glad to hear that is a focus for hopefully public policy coming up. And, it takes me back to the days when my preventive medicine, mentor was trying to was trying to get me to join the EIS. For those of you who don't know, this is the Epidemiology Intelligence Service. There's such a great program that the CDC runs that, trains and then deploys folks to states. So maybe we need an EIS for data scientists, to just embed them in, states to build that capacity, because it's not just state health departments, state Medicaid agencies. I mean, they've been decimated, with state budgets. So that's a really good point about this workforce. It's not just the frontline caregivers. Okay. Last minutes, we're going to focus on the year ahead. Now, we've all touched on sort of some lessons learned. I know the title of this session was "And the Next Pandemic," but I have to tell you, we're not through this one. And what we're doing now is going to set us up. Hopefully, we will learn, from this pandemic better than others. So what do you want to see happen in public policy? If you could just, ask for this new administration, this new Congress that we've heard from yesterday and today, what can they do? What should they do to help each of you in everything you've discussed, each of your sectors, make more significant progress? Kara, let me start with you.
Thanks, Lisa. I'm really hoping by fall we can recognize that this is a moment to rebuild and reinvest in our public health infrastructure, but also use it as a way to invest in value and population health. It's a launch pad for us to build out a more robust and community-engaged health system where we have partnerships all the way through, from state partners all the way on the ground in our primary care infrastructure, and really aggressively move to value. I think that is something we could and should do, because we're recognizing that social inequities equal health for all of us it's not just them over there, but it really impacted every single one of us in this country and across the globe. And so we can marshal our innovative mechanisms and figure out how to build that out. And then, just reinforcing that we have to create trust. We have to figure out how to kind of love and embrace everyone around us as a moment to rebuild and elevate, equity as a national imperative. I think we're getting there. I'm hopeful. I'm optimistic. Some days I'm not as much, but I think rebuilding requires all of the elements that we've talked about today: supply chain, private-public partnerships, and leadership.
Yeah, great. John, Brian, and then Shereef will have the last word for this morning. So, John, over to you.
Yeah.
What do you want to do? What's this town? What is DC supposed to do next?
Well, there's plenty, clearly. I guess one sort of slice that is one that is sort of near and dear to my heart is this concept of a National Center for Pandemic Prediction and Forecasting. It's something that has come up. It's been talked about. We've been thinking about this for years, this really focused federal effort that is all about collecting the right appropriate data, both at the national but also global scales, but also turning this sort of pandemic forecasting and modeling into a real discipline that's used to make key decisions. We're often left flat-footed, and of course, what happened with this pandemic is that we turned to a lot of modelers who are phenomenal, and there was no sort of cohesive, sort of synthesized way of pulling this all together. So, it's a data issue, but then also the discipline of how we interpret and create, identify key metrics at the earliest stages of pandemic. It's in the pipeline somewhere. I hope it gets the funding it deserves.
Great. Thanks, John. All right. We need a pandemic preparedness czar. I think we had one, didn't we, before? And then the office got abolished. But anyway, I said Brian next and then Shereef. So Brian, over to you.
Ditto to everything that Kara and John just said. Those are really important things. I think there are some good proposals already being bandied about around the greater supply chain, certainly genomic surveillance and population serosurveillance of all infectious diseases over time, not just late stage of a pandemic, so that we can track the mutations, because this happens with every pathogen that circulates. But also even things like the national supply stockpiles of simple things like PPE and a whole lot of other things that can predictably be used for lots of different things. So you don't want to just prepare for the last thing that you battled. You want to be able to prepare for what the healthcare system needs for lots of other things going forward. And, but I think we need to mostly not lose the focus on the fact that we recognize these needs. And then when the next inevitable thing happens this summer, or, an economic change or something else, we all of a sudden lose the political will to invest in things that we all know we need to invest in, and frankly are such a tiny fraction of the total cost of the healthcare system that they should be no-brainers for us to collectively agree to invest in. And I think the CDC and HHS need to lead that charge and be seen by the public and certainly every clinician in America as the source of the best epidemiology and expertise globally that we need to follow.
Yeah, great. All right, Shereef, bring us home.
Thank you. I'll be brief and just build on the comments of my co-panelists, just taking from the point of analytics to execution, especially on behalf of communities of color. It's not just saying the right things, and it's not just recognizing the issue. We need reform for the capital funding system for safety net institutions, everything from FQHCs to safety net hospitals and everything in between. We need to build the workforce, the healthcare and preventative care workforce of the future, caregiver workforce from these communities, drawn from people who are trusted and from these communities. And we need reform in payment and Medicaid and uncompensated care. That is putting our money as a country where our mouths are when it comes to real reform. And now is the chance, when we've seen these communities be devastated, and when we've seen the spillover effects on everybody, as Kara mentioned. And those are just a few things that I think we should be pursuing and advocating for as we proceed forward. So thank you.
Wonderful, Shereef. Well, If I could, or if we were in a real hall, right now you'd be hearing thunderous applause as I call for the audience to thank all of you for such a great conversation. And, next year, let's hope we're back in real life, IRL together. But thank you, Kara, Shereef, Brian, John, really terrific, and really glad you were able to join us today.